Radiological and imaging procedures for abdomen. The common radiological and imaging procedures for abdomen include 1. Plain radiography, 2. Barium studies for the gastrointestinal tract, 2. Ultrasonography for the gallbladder, cystic duct, bile duct, pancreas, kidneys, spleen, abdominal vessels, uterus, ovaries, and prostate, 3. Hysterosalpingography for uterus and fallopian tubes, 4. Aortography and selective angiography for coeliac, superior and inferior mesenteric vessels, iliac vessels and renal vessels. Plain SKIAGRAM of abdomen. Nomenclature. Anteroposterior plain SKIAGRAM of the abdomen has been variously named, as the straight film, survey film, scout and KUB film. When done in a case of acute abdomen, it is often called a straight film. A scout film is obtained before taking a contrast radiograph. A KUB film is taken primarily for examining the kidney, ureter, and urinary bladder, for which the acronym KUB stands. Preparation. In cases of emergency, requiring urgent surgical intervention, a straight film is taken without any preparation. However, in chronic conditions it is better to prepare the patient to obtain a clear and good picture. The object of preparation is to make the gastrointestinal tract as empty as possible, free from food in the stomach and from gases and fecal matter in the intestines. This may be achieved by 1. Using anti-flatulence for 3 days like enzyme preparation charcoal tablets and laxatives. 2. Avoiding oral feeds for about 12 hours before the investigation. Constipated subjects may require an enema to empty their bowels. In a picture taken without any preparation, the shadows of the gases and fecal matter may completely mask the significant findings. Reading of SKIAGRAM. The plain SKIAGRAM of the abdomen can be studied systematically in the following way. Sony shadows, the radiograph show, 1. The lower ribs, 2. Lumbar vertebrae, 3. Upper part of hip bones, 3. Sacrum with the sacroiliac joints. However, the whole of the pelvis may have been included in the exposure. The bony shadows are used as landmarks for the assessment of the position of viscera and of existing abnormalities. Any variation in the ribs and vertebrae, if present, may be noted. Sail shadows. The faint shadows of the following structures may be seen. 1. Domes of the diaphragm, 2. Psoas major, 3. Kidney made visible by the perirenal fat, 4. Liver beneath the right dome of diaphragm, 5. The spleen. Gas shadows are seen as black shadows because gases are radiolucent. 1. Gas in the fundus of stomach appears as a large bubble under the left dome of diaphragm. 2. The scattered intestinal gas shadows are often intermixed with the shadows of fecal matter. Abnormal shadows. Various abnormal shadows may be seen in different diseases. Alimentary canal, barium studies. Contrast medium. The alimentary canal can be visualized and examined radiologically by using a suspension of barium sulfate in water. Barium is radio-opaque because of its high molecular weight. Barium sulfate is absolutely harmless to the body and is not absorbed from the gastrointestinal tract. Barium sulfate is not soluble in water, and can make only a suspension or emulsion in it. Principle involved. The passage of barium through the lumen outlines the mucosal patterns, which can be examined under a screen, fluoroscopy, or radiographed on a film. Barium swallow. 50% suspension of barium sulfate is to be swallowed 2-3 times with patient standing behind fluoroscopic screen. Barium swallow shows the normal position of esophagus as it lies posterior to aortic arch, left bronchus, and the left atrium of heart. Enlargement of left atrium would show narrowed esophagus. Barium meal examination. The subject is instructed not to eat or drink anything for 12 hours before the examination. Administration of contrast medium. The patient is made to drink 300 to 400 cubic centimeters, 10 to 15 ounces, of a 5% barium sulfate suspension in water, and then examined under fluoroscopy. Thus, the entire alimentary canal can be examined by following the barium and taking successive radiographs. The stomach and duodenum are visualized immediately after the barium drink. The medium reaches the iliacecal region in 3 to 4 hours, the hepatic flexure of the colon in about 6 hours, the splenic flexure of the colon in about 9 hours, the descending colon in 11 hours, and the sigmoid colon in about 16 hours. It is usually evacuated in 16 to 24 hours. However, some barium may persist in the large intestine for several days. As barium enters the stomach, it tends to form a triangular mass below the air in the fundus. It then descends in a narrow stream, canalization, to the pyloric part of the stomach. In addition, the shape, curvatures, peristaltic waves, and the rate of emptying of the stomach can also be studied. Duodenum. The beginning of the first part of duodenum shows a well-formed duodenal cap produced by poorly developed circular folds of mucous membrane and protruding pylorus into it. The rest of the duodenum has a characteristic feathery or floccular appearance due to the presence of well-developed circular folds. Jejunum and ileum. The greater part of the small intestine presents a feathery or floccular appearance due to the presence of transverse mucosal folds and their rapid movements. However, the terminal part of the ileum is comparatively narrow and shows a homogeneous shadow of barium. Large intestine. It is identified by its smooth outline marked by characteristic haustra or saculations which are most prominent in the proximal part and may disappear in the distal part. Acute curvatures at the flexures cause superimposition of the shadows. Occasionally, the appendix may also be visible. Diseases of the large intestine are better examined by barium enema, which gives a better filling. Barium enema, preparation. 1. A mild laxative is given on 2 nights before the examination. 2. A plain warm water enema on the morning of examination. Contrast medium. About 2 liters of barium sulfate suspension are slowly introduced through the anus, from a can kept at a height of 2 to 4 feet. The enema is stopped when the barium starts flowing into the terminal ileum through the iliacecal valve, as seen under the fluoroscopic screen. Appearance. The rectum and sigmoid colon appear much dilated, and the colon shows characteristic haustrations. The outline of the colon and the haustra may be accentuated by the double contrast method, in which the barium is evacuated and air is injected through the anus to distend the colon. In the background of air, the barium still lining the mucosa makes it clearly visible. Pyelography. Pyelography, urography, is a radiological method by which the urinary tract is visualized. The radiograph thus obtained is called a pyelogram. It can be done in 2 ways depending on the route of administration of the radiopopaki dye. When the dye is injected intravenously, it is called the excretory, intravenous or descending, pyelography. When the dye is injected directly into the ureter, through a ureteric catheter guided through a cystoscope, the technique is called retrograde, instrumental or ascending, pyelography. Excretory, intravenous or descending, pyelography, preparation. In addition to routine abdomen preparation, for 8 hours before pyelography, the patient is not given anything orally, all fluids are withheld, and diuretics are discontinued. 2. Patient is asked to empty his bladder just before the injection of the dye. Administration of the dye: 20-40 cc of a warm iodine compound, urographin 60% or 76% Conray 420 or Conray 280, which is selectively excreted by the kidneys, is slowly injected intravenously. Care is taken not to push any dye outside the vein because it is an irritant and may cause sloughing. How to do? Serial SKIAGRAM, excretory pyelograms, are taken at 5, 15, and 30 minutes after the injection of the dye. Maximum concentration is reached in 15 to 20 minutes, and by 30 minutes the dye fills the urinary bladder. Intravenous pyelography is an anatomical as well as a physiological test because it permits not only visualization of the urinary tract but also helps in assessment of the functional status of the kidney. Normally, 1. Minor calyces are cup-shaped due to the renal papillae projecting into them. 2. Renal pelvis is funnel-shaped. 3. Course of the ureter is clearly seen along the tips of the lumbar transverse processes, the sacroiliac joint and the ischial spine, up to the bladder. 4. Bladder appears oval or triangular in shape. Retrograde, instrumental or ascending, pyelography. Preparation of the patient is similar to that for descending pyelography, injection of dye. The technique is quite difficult and can be done only by urologists. A cystoscope is passed into the urinary bladder through the urethra. Then the ureteric catheter is guided into the ureteric opening and passed up to the renal pelvis. Through the catheter, 5 to 10 ml of a sterile solution of 6-8% sodium iodide, Conray 280, is injected. As the renal pelvis is filled to its capacity, the patient begins to complain of pain, when further injection must be stopped. General anesthesia is therefore contraindicated because of the risk of overdistension of the pelvis. If the renal pelvis admits more than 10 ml of the dye, hydronephrosis is suspected. An ascending pyelogram can be distinguished from a descending pyelogram because a. Only one pelvis is outlined. b. The catheter through which the dye is injected can be seen. c. Biliary apparatus. d. Investigation of choice. e. The investigation of choice for gallbladder is ultrasonography. It can be undertaken on a lasting patient. Gallbladder is seen as a cystic oval shadow with a narrow neck in the right upper quadrant along with visualization of the bile duct and portal vein. However, endoscopic retrograde cholangiopancreaticography, ERCP, can be carried out to outline the intrahepatic radicals, bile duct, pancreatic duct, and gallbladder through the oral route via an endoscope through which a catheter is inserted and the contrast is injected into the common bile duct. Ultrasonography of abdomen shows pancreas and related structures. Oral cholecystography is an outdated method for visualizing the gallbladder by taking radiopaque dye which is exclusively excreted by the liver and concentrated by the gallbladder. The contrast is taken overnight and X-rays are taken 14 to 16 hours after the intake of the dye and gallbladder, cystic duct, and bile duct can be seen. It is, however, dependent on the proper absorption from intestines. Uterus of the female pelvis is seen by ultrasonography. Hysterosalpingography, This is a radiological method by which the uterus and uterine tubes are visualized and their patency confirmed. The radiograph thus obtained is called a hysterosalpingogram. The investigation is done preferably within the first 5 to 10 days of the menstrual cycle. A tight-fitting cannula is introduced into the internal os of the cervix. The cannula is connected to a syringe through which 5 to 10 ml of an iodized oil, lipiodol, are injected, and the SKIAGRAM taken. The shape and size of the uterus and of the uterine tubes are studied. Spilling of the dye into the peritoneal cavity is noted. Hysterosalpingography is usually done to determine the patency of the uterine tubes in cases of sterility. However, it is also of value in the diagnosis of anomalies of the female genital tract. The female pelvic organs can also be seen by ultrasound. Enphedogram, O-plane X-ray of the abdomen in a full-term pregnant lady showing the foetus with vertex presentation. The shaft of bones of upper and lower limbs and body of vertebrae can easily be identified and appreciated. P.